Haya, DJ kwenye 1 na 2. Good morning, guys. So today we are going to talk about intussusception. So this is one of the rare cases in medicine. However, it's the most common is one of the most common abdominal images affecting the children under 2 years. And it happens when one portion of the bowel slides into the next. We all scientists here, we know the telescope, right? So those tubes of different size in telescope, you can put it as in the intestine. So one portion of the intestine may invaginate the proximal or distal portion of the bowel. So when this telescoping happens, the flow of fluid and food through the bowel can be broken, and the swelling and bleeding may occur, and the blood supply may be affected. So there may be poor perfusion to the bowel, and eventually the bowel may go to ischemia. So as I said, intussusception, it's very rarely. It may affect 1 to 4 newborn out of every 1,000. And the most common age is 5 to 9 months. However, older kids may be affected, and it's more common in boys. As you see, this is an image which try to brief the intussusception. We have can everybody see the image, right?
Yes, I think they can. Robert.
So we have the ileum and the colon. The ileum telescopes inside the ascending colon and obstructing the passage of intestinal content, which may lead to bleeding and eventual edema, strangulation of the bowel, then gangrene, sepsis, or shock, and may lead into death of the patient. So this is another image. As you can see, there is the small intestine, which is inside the colon. And this is another image, as we can visualize. There is the intestine, which invaginates into the colon, as we can see. So intussusception is the most common cause of intestinal obstruction in patients aged 5 months to 3 years, and accounts about 25% of abdominal images in children up to 5 years. So there are studies which were done in Swiss and USA, which found an incidence of 38 and 56 cases per 100,000 live births, respectively. And the most common site of the intussusception is ileocecal. It's at the ileocecal junction, where the small intestine meets the large intestine. So we have symptoms. What are the symptoms? Usually there is abdominal pain. This symptom accounts about 8% of other symptoms, and the pain is colic. However, sometimes in kids which cannot talk, it's very difficult to know the nature. But for the kids who can talk, the pain is colic, and most of the time, kids have this discomfort associated with crying excessively, and it's paroxysmal. It may come and go, but consistently. After every 10 to 20 minutes, the patient may complain about abdominal pain. Also, there is vomiting and current jelly stool. And one of the symptoms can be the sausage-shaped mass, often on the right upper quadrant. where there is the colon. We can appreciate more there. So in summary, there is a triad of the symptoms. These, we may consider it as the classic symptoms of the intussusception: the abdominal pain, current gel stool, and vomiting. This accounts more than 50% of the patient. So whenever you guys, you have a patient with these symptoms, abdominal pain, current gel stool, and vomiting, you should think about intussusception. There is an image of current gel stool, as you can see. Sometimes it's very difficult. It may be not like real blood, the bright red blood. It may not be like that. Yeah. So coming down to signs and symptoms, the patient may be lethargic. You may palpate the sausage-like mass on the right upper quadrant, the absence of bowel content on the same side, but on the lower quadrant, and the abdominal distension. Later we may see the dense sign. But also when you do the DRI, you may find the blood, mucus, or current gel stool. And occasionally, to some case, you may feel the intussusception, the bowel itself. So on examination, there may be the one of the signs. It's the dense sign. When you palpate on the right upper quadrant, you may feel or appreciate the sausage-like mass. And to the lower quadrant, the abdomen may be empty. So whenever you do this examination, it must click or crop to you. Maybe you're dealing with the intussusception. So most of the time, the cause is idiopathic. And another causes may be viral infection, such as rotavirus and adenovirus, may cause the verticulum, enlarged pia patch, and polyps or tumors in older kids. So coming down to diagnostic of intussusception, there is laboratory and radiological. Most of the time, labs cannot give you something. Laboratory, it's not that much necessary. And so you may do your labs according to the symptoms of the patient. Investigation, which is very crucial, it's abdominal ultrasound. This has high sensitivity and specificity. And you may find the mass measuring 2 to 5 centimeters in diameter on the right side of the abdomen. And you may find the concentric rings of tissue presenting the component of the bowel wall and mesenteric fat. Sometimes these findings are referred as donut or target sign. And the donut sign is there is hypoechoic outer rim and the central hypoechoic on the transverse view. So outside there is hypoechoic, and on central there is hyperechoic, as we can see on the images. On the central there is hypoechoic, and the outer there is hypoechoic. So on the longitudinal section, the mass is roughly ovoid in shape, with the different tissue appearing layered longitudinally, and the appearance is sandwich or pseudo-kidney sign. We all know sandwich, right? So there is, as we can see, there is multiple longitudinal line.
So let me just interject there. So basically, if you go back to the previous image, all right, it's if you make it simple for people, you all have seen a target, right? Like those in cartoons, we have seen targets. So that's what you'll see when you are in transverse view. So transverse view meaning that that probe marker is looking to the right of the patient, And then when you scan from the right upper quadrant with a linear probe, mostly in the kids, if you scan from the right, go up again to the center left quadrant, and if you find anywhere whereby there is no kidneys or spleen, but you find something like this, then you have a diagnosis of intussusception. And if you put it in a longitudinal view now, whereby the probe marker is facing the head of the patient, okay, that is where now you will find the pseudo kidney, whereby there is no kidney, but it looks like a kidney. So that also is intussusception for you. And it's obviously operator dependent, like he said.
Okay, thank you, Dr. Moise. Then it's very crucial to do the abdominal X-ray, and in abdominal X-ray, you may find the meniscus sign, and these may be you may see like a crescent of gas within the coronic lumen, outlining the apex of the intussusception. And you may see sign of small bowel obstruction. You may see the bowel dilated. So these, as we can see, the meniscus sign on both images, we can appreciate it. And we may see the bowel dilated. This implies that the patient has already intestinal obstruction. So abdominal CT scan, it's good to do abdominal CT scan when the environment can support you, because most of the time it's time consuming, because kids, especially for children who may require sedation. So for the patient in whom the other imaging modalities are unveiling or to characterize the pathological read points for intussusception detected by ultrasound, you may do the abdominal CT scan. So management-wise, first of all, you need to stabilize the patient by giving NGT for decompression. Patients are prone to dehydration, so IV fluids and antibiotics because of the infection. And the patient laparotomy may be done, but there are indications for laparotomy in case of perforation, maybe prolonged history, more than 24 hours, and peritonitis. So why I chose this case, because we had a patient here. We had a patient in our facility like 1 week ago. This patient was 7-month-old male, not known to have any comorbidity. The patient attended our facility 2 times on the same day due to chief complaint of abdominal pain, vomiting, and fever for 1 day. The pain was gradual, progressive, increasing in severity. The baby was very irritable and restless, not relieved by paracetamol, and it was associated with non-projectile vomiting, and the vomiters contained recent food and milk, more than 2 episodes. However, the mother reports normal passage of stool. So the fever was of sudden onset, progressive, no periodicity, no history of convulsions, painful swelling, ear discharge or scratching, no history of cough, difficulty in breathing. On examination, the kid was conscious, not pale, jaundice, tachycardic, dyspneic, no sign of dehydration with stable vitals. Baseline investigation were done, which were essentially normal. So the patient was discharged home with supportive medication, paracetamol and ondansetron. So same day, the patient came back at ER with the chief complaint of vomiting and fever. However, there were no abdominal pain, discomfort, and the mother collected the stool, which was normal initially, was normal in texture and color. So on examination that night, it was essentially normal. There is nothing significant were recited. So on waiting the lab results, the patient had one episode of current gel stool, which was normal in amount, non-foul smelling, no abdominal pain, and no vomiting reported. So the stool analysis results come out, which was normal. Then the patient was discharged home with working diagnosis of viral gastroenteritis. So why we chose this case? Because if the patient, it may croak to you, if the patient come to your facility for the second time on same day, we must think outside the box. It's very crucial to recrack the patient and to do thorough physical examination. And the red flag here was we missed the current gel stool. It was alarming sign. So it was very crucial to do the point of care ultrasound and detailed abdominal ultrasound and abdominal electron X-ray for this patient because of that current gel stool. Continuation of the symptoms were persisted since morning up to the night. So it was very important to do more. So since the patient came for the second time with the same complaint, it was important to consult pediatric and EM consultant for second input. Thank you.
Thank you, Dr. Dutler. That was a wonderful, brief, and very concise presentation. And a few points that before I give them, if there are any questions from the team here, Haris, Fatma, or Jonas, or Abir. If there are any questions, then from the floor, from people online, if there are any questions about this case, because this is the same case you will get next time also. And I'll share with you the different cases that. So basically this case is common. Like I had two cases and I'm going to give you an example of it. So first case was a patient with something coming out from the anus, okay, a baby. And we all thought it's rectal prolapse. So we admitted the patient, and then the pediatric surgeon called me to educate me, obviously. At that time I was a resident year 1 and I was in the pediatric wing. And he told me that this is a case of intussusception. He called me, he showed me the ultrasound, he showed me the x-ray, and just like the way Dr. Dutu said that there is a target sign, we saw that target sign. And after that, there was a kid that was a kid of my friend. She had gastroenteritis. Cramping pain, at one point she's fine. Okay, she's playing and everything. Another point, she's like devastated, she's irritable. And most of the times they'll draw their knees towards the chest. And that's very important to identify in this kind of cases, because it comes and goes. Like it is an intussusception. So when the bowel content passes through that lead point, that's the telescoping of one bowel part to another. Okay. And when that happens is whereby you start getting the cramping pain. Now that patient was having that. She went to one of the hospitals, not going to mention any names, and she was considered as having a viral bug. And they were like, okay, this is a viral case, give fluids, give Onda, and not improving. Vomiting, everything, bad vomiting bile, like yellowish nani vomitus. Ultimately to find out, and I had to probe the pediatrician that, hey, can you do an ultrasound, please, just to rule out the surgical cause? And they did that and they found a target sign. And immediately she went to. During internship, we had a case of more than 24 hours of intussusception. And that baby went into septic shock. Unfortunately, 2 months old, never came back, died. So age 6 to 6 years, that's the point number 1 to really remember. So point number 1 is age 6 to 6 years. 6 months to 6 years. That's number one. The triad: abdominal pain. What else? Current black, like it looks like jelly. Have you all seen that jam that you see that you eat? I'm not trying to discuss the matter, but like the jam that you see is similar. That is the current jelly stool that that patient will present with. Okay, and sometimes when you don't get that and the patient is having gastroenteritis, just do stool for occult if you are suspecting that. So you can do stool for occult, and if it's positive, then you might think, okay, this could be intussusception. So abdominal pain, current jelly stool, and what else did you say? And vomiting, right? Because these three is the triad of intussusception. And at the end of the day, when you have such a case, be very, very, very concerned. Don't just try to, ignore the case. And there is another presentation of intussusception which people forget to talk about. It's a neurological intussusception. I don't know how it happens. The pathophysiology is not known, but the child comes with seizure and abdominal pain. So if you have seizure, abdominal pain, think intussusception. If you have abdominal pain, vomiting, and current jelly stool, think of intussusception. And just like the way you need to know how to do ultrasound of the target sign and the pseudo kidney sign. So is there anything else from the team? Any questions that are concerning? Yes.
Thank you for the wonderful presentation, Luto. And I have just one question. In the presentation, you said the most common location is the ileocecal junction. Maybe is there a reason why that's the most common location? Is it because of the different caliber of the intestine? Like, what is the main cause? Why is it the main location?
Yeah, it is because of the different calibers. Because of it's very straightforward. Maybe Dr. Moise, if you can add something.
I think she with the question is very good.
Yeah.
That yes, it's a different caliber of the bowel.
The bowel, the colon, and the small.
So that's where there's a big colon, and then there's the small intestine, and that's very easy to
telescope.
So most of the times in our setup, it's the viral infection, by the way, which causes that. And then there are pyre patches, anything that can cause some sort of inward motion of your bowel, diverticulum, all this can cause intussusception, even in adults, by the way. But in pediatrics, it's very important that you don't ignore. So if your child is trying to bend their knees while having these cramps, if they're irritable and all of a sudden they're okay, think about intussusception. So gastroenteritis, basically, if you have gastroenteritis in a child, don't just think of one diagnosis. Think about appendicitis. Think about DKA. If you have not checked the RBG, check the RBG. If it's high, abdominal pain, it could be an early sign of DKA. So think of those differentials in the ER. ER is about identifying the lions, tigers, and things which can kill you. We are not concerned with the buffaloes and the giraffes. That is intermedicine job. Yes. Oh, people want to join. So Irfan, from surgery side, do you have anything to add?
No, Doc. This was a really good presentation.
Okay. Suhaila.
Yeah, hi.
Hi. Yes, Suhaila, we are asking if you have any questions.
No. I just want to tell you that it was a good presentation, and I had a similar case before. The kid had presented with a sudden onset of passing bloody stool. That was more than 24 hours, I guess. So it was like the end presentation. and we had to go in for the laparotomy emergency as we were scared it could be already gangrenous, but the kid survived.
Okay, alhamdulillah.
And I just wanted to add on something. Mostly in this kind of presentations, they also present with severe electrolyte imbalances and low hemoglobin levels. They usually do get anemia.
Definitely. That's a good point. Thank you so much. Yes, Harris.
Thank you, Dr. Adutu, for the very nice presentation. And I think it was very informative for all of us who are in critical care, because most of the times we tend to miss out on abdominal exams and even just simple things like checking the stool color of the child, because most of the time when they just come and we stick our heads to gastroenteritis and things like that. And it was very insightful to even give the idea that we can sometimes go ahead and do a point of care ultrasound to these babies and decide. Now, my question is actually something that Dr. Suhaila just mentioned. When do you decide that I can go for surgery or not? Or what is the definitive management? And how can you prevent this from reoccurring in these children in intussusception?
So do tell us. What do you think? So obviously, like a late presentation will require surgery. Okay. There are other modalities that Dutu has mentioned. However, there are something called hydrostatic enema. Hydrostatic enema is basically you're pushing enema, okay, with some sort of force, okay, and this opens up the bowel, like that telescoping is removed by doing that. So when you do that, okay, if especially on the kids, because they have the lead pipes, basically they have that lead point, so you can do that in the kid. If that fails, then you go for surgery, obviously. Or if they're septic looking, all right, if they're in shock, these are some of the indications that you have to go for surgery regardless of the condition. Yeah. But some of the surgeons, like if it's like a 24 hours thing, if it's more than 24 hours, I would not really wait. I would just go for surgery.
Is it possible for it to occur like two parts, like here and the other part?
Yes, it is possible to happen like that as well, because it's just pressure effect. That if you have a viral infection, for example, diarrhea, anemia, right, your bowels are like all messed up because of the bowel movement, and that pressure difference can cause invagination of the both bowels, and it can happen in either way. So
I have a comment.
yes, tell me. How do I?
So, just a point to note, since we see a lot of kids with AGE, and they may not initially present with the jelly current stool, it's important when we're discharging the patients to inform the parents on watching out for that presentation. Maybe as this child was normal stool, they went home, and then when they came back, it was also normal stool, and then they came to get the jelly current stool. And that's when we thought of intussusception. So any AGE child, it's important when discharging to give instructions to the parents that watch out for blood in stool or the jelly current stool, and the mass, those, if they see that, they come back immediately.
All right. So finally, now I was leaving the best for the last. Dr. Monada, do you have any inputs? She has commented, thanks for the session and keep up the good work. Thank you so much. Thank you for the presenter on a short notice that you presented this, and you did a wonderful job.
Hello.
Yes.
Am I audible?
Yes.
Okay. Just to congratulate Dutu, I think he's a great presenter. And I've learned from this session. I didn't know about these cases. Asanteni kwa kutuelimisha, and have a good day. I have to leave now because I need to start my clinics. Thank you, everyone.
All right. Thank you. Okay, I think that's the end of the session. And thank you very much, Dr. Dutu. Being on night shift, you still managed to present like as if you're on a day shift. So thank you so much. And yeah, Dr. Jonas will send out a timetable for everyone to present. The nurses can contribute too. You can give some topics to the nurses. They can present, and that way we'll build confidence of presentation, as well as keep up that morale of learning, because that's what we are here for, not for just work and politics. So, all right. Thank you so much. Have a good day.
Okay, thank you. Thank you for umechelewa. Umeshakata eh?
Nikata.
Yes, sir.
Msikate. Hi. Bye.